Good morning, everyone. Today I'll be presenting a case conference. The name of my patient is Kumari Anjali, 25 years old female, a single Hindu female living in a nuclear family, done her graduation in 2017, resident of Pauri, Uttarakhand, belonging to upper lower class social economic status according to modified Kuppaswamy scale. Identification mark, there's a scar mark of 1:2 centimeter on the little corner of the left eye. Admitted to the hospital on the 17th. The source of the information is the patient's father, Mr. Prem Ram, 55 years old male, who is working as a teacher and has been living with the patient throughout the illness. History given is clear, current, given in chronological order, and collaborated among all informants. The history is reliable and adequate. The complaints are chronic in onset, continuous in course, and deteriorating in progress. The chief complaints of the patients are decreased social interaction, suspiciousness, odd behavior, self-muttering, self-smiling, decreased sleep, decreased appetite, irritability with anger outbursts from the past 4 years. From the past 20 days, the patient has been physically and verbally abusive as well. The history of present illness is the patient was apparently well 4 years ago when after she finished her graduation and moved back home, her family members noticed she gradually started to show a decrease in interest in interacting with her family members. She would prefer stay alone most of the day. She would not reply when spoken to. After multiple attempts, she would reply in monosyllables or leave the room. This was contrary to her previous nature. She would be seen sitting alone, looking at the blank spaces for most of the day. When the patient would be asked to participate in household activities and functions, she wouldn't show any interest towards spending time with her siblings. She previously enjoyed engaging in conversation with her siblings. Her parents noticed changes in her behavior. She became fearful and would tell her family members that मुझे कोई मारने आ रहा है. She would believe people are looking at her and talking about her. She believed that especially the neighbors looked at her when she went outside. She would be seen lying in a bed covered with a blanket throughout the day. She became suspicious that the food being served to her and stopped consuming the food from outside or from neighbor's house. Her mother would ask her to eat food. She would reply, मैं नहीं खाऊंगी, कुछ मिलाया हुआ है. When her mother would serve her food, she would hide the plate in various corners of the house, like under the bed. After a while, she would go herself to the kitchen, serve herself food from the main vessel, allowing no one to touch her food or enter the kitchen. This was contrary to her previous nature, wherein she would enjoy having meals surrounded by family. Gradually, she stopped consuming food. There were instances where she would be seen sitting alone, smiling or muttering to self. She, she would be moving her lips as if talking to someone, but the word would not be understood by the family members. This would occur any time of the day with no diary variation reported. When the family members would question her behavior, she would not give any explanation and would stay quiet. She stopped showing any interest in normal daily activities. She would hardly have a bath, and with passage of time, she stopped changing her clothes as well or combing her hair. She would also urinate in her clothes. On being asked to do normal daily activities and maintain hygiene, she wouldn't appear to be listening. The patient also developed difficulty in onset of sleep. She slept not more than 2 to 3 hours per night. She would be seen sitting in the bed the whole night, staring at blank spaces, not replying when family members tried speaking to her. Citing these problems, the patient parents took her to RML Delhi, where she was investigated and managed conservatively. She was started on oral antipsychotics and was maintained on them. She carried out the normal daily activities and learned to put mehendi and was working as a beautician and was also trying to do a knitting course. 2 months ago, the patient's mother noticed that she stopped consuming her medications. She would ask her mother to leave the medication on the table and would hide them and would question her parents on why did she need to keep them. For the past 20 days, similar complaints were seen by the parents, which she would not show any interest in interacting with the family members. She also stopped consuming food believing that her mother had put something to harm her. Now, when her mother would give her a plate, she would become irritable and scream, "Mujhe nahi khana." On being provoked by mother to consume food or have a bath, she would become irritable. She would be seen lying in a bed for the whole day, not replying when spoken to, and would be continuously scrolling through her phone, fidgeting with her hands. Her family members would question her behavior. Then she would become irritable, and episodes of anger outbursts were seen. She would now be verbally and physically abusive towards her sibling and mother. When a mother would provoke her behavior, she would be verbally abusive, pick up the household articles like the table fan and throw them, or even push her mother. She would also be spitting at odd places at people when they would try to question her. She was also seen on multiple occasions muttering to self, pulling her hair strands out. With passage of time, she stopped taking interest in grooming herself or consuming food and would stay in the bed the whole day, looking at her phone. This is the illness graph of the patient, where the onset of the illness is in 2017, which she was taken to RML and was started on oral antipsychotics. She was compliant on medications for till November 2021, where from the past 20 days, similar complaints have been seen, and irritability and anger outburst was also seen. Negative history, no history of suggestive of seeing of things that cannot be seen, thoughts being introduced into or taken away from mind by external agency against the will, own thoughts being heard aloud or being known to others against the will, feeling, drive, actions, or sensation being under the influence of some external agency. No history suggestive of low mood, over cheerfulness, over religiosity, over spending, decreased need for sleep, over familiarity, big planning, or over grooming. No histories of head injury, loss of consciousness, abnormal body movements associated with incontinence, tongue bite, frothing from mouth, uprolling of eyeball, memory impairment spells, injury, blurring of vision, or double vision. No history of vomiting, unexplained weight loss, headache. There's no history of any substance abuse. The treatment history is inadequate as they were not all prescriptions were not present. Uh, Risperidone was started in September 2017 and it was continued till 2019 to 2020. The maximum dose were given was 4 mg in 2 divided doses. The September 2020. 10 mg divided dose was given. The response was adequate, compliance was good, side effects were none. Um, Amisulpride was started in 2020 and was continued till November 2021, wherein the patient was not compliant in consuming medication after November 2020. Past history, no significant past medical or surgical history. Family history, there is no history of any psychiatric illness or any history of medical illness in the family. A patient is second in order of 4 siblings, born of a non-consanguineous marriage. Patient lives in a joint family with a parents, sibling, and paternal grandfather. No history of any psychiatric illness in the family. Patient has a cordial relation with the parents and sibling. The economic head of the family is patient's father, and the emotional head of the family is patient's mother. Patient is closest to his mother in the family. Family is supportive towards the patient, has sympathy towards his illness, understands importance of regular follow-ups and compliance. Full-term normal vaginal delivery at home. The patient cried immediately after birth. There is no history of fever, synopsis, prolonged jaundice, breathing, breath-holding spells, abnormal body movements, or admission to NICU. There is no history of antenatal, internatal, or postpartum complication. All development milestones were achieved as per age. Complete immunization was done as per schedule. Exclusive breastfeeding for the first month of life and weaning thereafter. In childhood history, the child was born in Pauri in Uttarakhand. There is no history of hyperactivity, inattention, impulsivity, repetitive bullying, other children, stealing, lying, disobedience, fire setting, nail biting, thumb sucking, hand banging, bagging, bed wetting, or stuttering during childhood. The home atmosphere in childhood and adolescence, there is no history suggestive of broken home, discretion by parents, step parents, or adopted sibling. Patient has a cordial relation with all her family members. The scholastic and extracurricular activities. Patient started schooling from 4 years of age, went to a school near her home in Pauri. She was a shy child in school and did not take part in any extracurricular activities. An average student in school and cleared class 10th and 12th in the first attempt. She went to Rampur to finish her graduation, after which she shifted back to Pauri. Occupation. Patient was working as a beautician before the onset of her illness. Sexual history. Patient attained puberty at 11 years of age with start of Talarke. The history of act of masturbation or any consensual sexual act cannot be attained. Pre-morbid personality. Patient is ambitious and wants to earn money to give her family members a better standard of life. Social relation. The patient had good social interpersonal relation with family and friends. She is responsible towards the studies and family, work and leisure, enjoyed chatting with her family members. Patient enjoys working with her mother in normal daily household chores. Mood is stable, can express inner feelings of sadness, anger, or frustration. Seldomly gets angry over minor issues. Character. Patient was shy at school, reserved by nature. Patient had difficulty in interacting and making friends. The attitude and standard, religious by nature, attended puja, visiting temple with family, abides the law and respects the social norms. Habits. Patient has a regular sleep-wake cycle and rhythmic bladder and bowel habits. The impression is that she had a well-adjusted pre-morbid personality. In general examination, she's a lean-built female. Her body weight is 44 kgs, height is 160 centimeters, and BMI is 17.18. No pallor, icterus, clubbing, synopsis, edema, and lymphadenopathy was seen. She is afebrile. Her pulse rate is maintained at 84 beats per minute. BP is 110 by 80, and respiratory rate is 18 breaths per minute. In respiratory system, this bilateral air entry is equal. Trachea is centrally placed. Chest movement is bilaterally equal. In CVS examination, S1 and S2 is present. No murmurs present. In GI system, soft, flat, no dilated veins, scars, umbilicus centrally placed. In CNS, the plantar is downglowing. No cerebral and meningeal signs were seen. In MSC, the general appearance and behavior, endomorphic build young female, estimated as per stated age, sitting in a stoop posture for most of the time with downward gaze, involved in herself. Grooming and hygiene is not maintained. Hair is minimally kept, pulling the hair strands continuously, wearing untidy clothes. She is dressed appropriately, appeared her stated age, appears to be in touch with her surroundings, eye contact not initiated, sitting with a downward gaze. Attitude is withdrawal, rapport is not established. Patient has been sitting in the bed most of the time on her own, hence psychomotor activity is decreased. Speech. Patient is not verbally responsive, replying in monosyllables after multiple attempts. Attention is arousable with difficulty but could not be sustained. Higher mental functions could not be done as patient is not cooperative. Therefore, Kirby's method was applied, in which the general reaction and posture was seen where the attitude is passive, the voluntary posture is comfortable. Patient is not maintaining any awkward or uncomfortable positions. Behavior. The patient is verbally and physically abusive towards staff and physician. Patient does not eat voluntary. She has to be prepared. She cannot dress or undress herself. She is untidy, however, goes to washroom and asks multiple times. Her attitude does not change before, during, or after the interview. She remains withdrawn. Facial expressions, no signs of emotions throughout the interview. Eye opening, fixed downward gaze. Patient is not following any commands throughout the interview. Echolalia, echopraxia, and automatic obedience are absent. Muscular reactions, muscles are relaxed when limbs and body are moving. No abnormal body movements, no drooling of saliva or protrusion of tongue is seen. Emotional responsiveness, no feelings are shown throughout the interview. Speech, patient is not verbally responsive, replying in monosyllables after multiple attempts. The patient is not cooperative to hold a pen or paper. Patient is kept on a primary diagnosis of undifferentiated schizophrenia and of a differential diagnosis of a paranoid schizophrenia. The management of the patient is citing the progression and complaints. Patient is being brought to the hospital by parents for management and treatment. She was admitted under section 89 with consent of the parents. Detailed history and examination were done. Blood investigation were done. In acute management, to manage the patient acutely, patient was started with injectable antipsychotic to chemically restrain her. Vital monitoring was done 8-hourly. Family members were psychoeducated about the illness. In long-term management, plan is to start the patient with oral antipsychotics. Risperidone can be started as patient had psychoeducation of the patient and the family is planned. Compliance therapy to be discussed with the patient and the family members. The MSc done on 19th is that a Eldovolovic built young female estimated as per age is sitting in a stoop posture with a downward gaze. Grooming and hygiene is now maintained, appears to be her stated age. Eye contact is not initiated. Attitude is withdrawn. Rapport is not established. Psychomotor activity is decreased. Patient is not verbally responsive, only replying in monosyllables after multiple attempts. Attention is arousable again with difficulty but cannot be sustained. In Kirby's method, the attitude is passive. She is not maintaining any awkward or uncomfortable positions. The patient is not verbally or physically abusive towards the staff and the physician. Patient eats voluntarily and asks for food and even asks to go to the washroom. Her attitude does not change before, after, or during the interview. There are no signs of facial expressions seen throughout the interview. Eye opening is still fixed, a downward gaze. Patient is not following any command throughout the interview, and there are no feelings shown throughout the interview. Speech is, patient is still not verbally responsive and replying in monosyllables after multiple attempts. Thank you. Patient is kept on a primary diagnosis of undifferentiated schizophrenia and of a differential diagnosis of paranoid schizophrenia.
Questions from
remission is that we are not able to see any symptoms for 6 months, which we do by applying the scales. If there are no symptoms present for 6 months, then there is complete remission. A study was done on clozapine, schizophrenia working.
Aditi, what are the points in favor of diagnosis?
The points in favor of diagnosis is that the onset of illness, the age of the patient is one of the points. And the patient, throughout the history, there have been negative symptoms present in the patient. That the patient, there is a lack of speech is present, and the patient, there is no emotional responsiveness present in the patient, and there is hallucinatory behavior present in the patient, which is evident by the self-muttering and self-smiling seen by the parents. And the parents also give an history that the patient has delusion of persecution present, where she believed that she did not want to eat any food, that it was that something was being mixed in it. So therefore, we can think about paranoid schizophrenia, but it does not fulfill all the criteria. So paranoid schizophrenia, so my primary diagnosis will be undifferentiated schizophrenia, as it is not able to fulfill all the criteria for paranoid schizophrenia. To move forward with the case, I will firstly psychoeducate the family members to assure that the patient is consuming the medication. Because for the 4 years when she is compliant on medications, no symptoms were seen. And when the parents started believing that the patient is consuming the medications and she wasn't, then all the symptoms reappeared. So I will psychoeducate the parents and the patient about the compliance for the medications. And then I would preferably start her with risperidone or amisulpride, because a good response has been seen in past with the similar medications.
So coming to the comments about the presentation. First of all, when you were presenting the onset, like, what do you mean by that? And what do you mean by what do you understand by disorganized?
This organized behavior is that she's not able to maintain her grooming and hygiene. She's urinating in her clothes. There was a history episode given by her parents that when they asked her to go to the washroom, she just urinated in her clothes, and she's not consuming, she stopped consuming the food totally.
Do you know the definition, exact definition, what is disorganized behavior? And in your treatment history card, you were writing response. In response, you were writing
Good.
What have you written?
Good response.
So all the medications, to all the medications, the patient
Yes,
had good response.
the parents have not reported of any symptoms throughout the 4 years where she has been compliant on the medication. The only reason where the medications have been changed is because due to COVID, she was not able to go to the regular medical professional which she used to go to. So therefore, there have been a shift in medication in the middle.
How we categorize the response in the treatment history? Like we mention it as partial response, good response, poor response. Okay, I want you to read about that. And, okay, rest. Nice presentation.
Thank you.
Some lacuna was there, but it can be improved in further presentations. Okay, thank you. All the best.